Hi, my name is Cindy Head, your content expert for Modules 3 and 4, Lifestyle Interventions. Module 3 is divided into two sections. First, we will discuss the ADA clinical practice recommendations for nutrition therapy, followed by an introduction to basic carbohydrate counting. Medical nutrition therapy should be received by all people with diabetes according to national standards and diabetes self-management support when their diabetes is first diagnosed and as needed thereafter. It is recommended for type 1 and type 2 diabetes and should be provided by a registered dietitian who is knowledgeable in the components of medical nutrition therapy. It's provided as needed to achieve treatment goals as well, and because it can result in cost savings and improve outcomes such as a reduction in A1C, it should be adequately reimbursed by insurance and other payers. The priority of nutrition therapy for type 2 diabetes is to implement lifestyle strategies that will reduce hyperglycemia and hypertension. Also, strategies that can help to improve dyslipidemias. It's important to remember that we need to set gradual, realistic, and culturally appropriate goals for our patients, but the overall emphasis of our therapy should be to help improve metabolic outcomes by modifying nutrient intake and lifestyle. So let's talk about the nutrition goals for diabetes. Obviously, we want to try to attain and also maintain normal or as close to normal range as possible glucose, blood pressure, and lipid levels. We also want to prevent, delay, or treat conditions with nutrition-related implications, such as low blood glucoses, sick day rules to prevent hypoglycemia and hyperglycemia. We also want to try to prevent chronic complications such as kidney disease, hypertension, and heart disease, while maintaining the pleasure of eating. We need to remember to use scientific evidence to teach what food choices to limit. For example, it's okay to eat sucrose or table sugar, but sugar-sweetened beverages should be limited. The ADA recommendation for blood glucose levels for fasting or before meals is 70 to 130 milligrams per deciliter. 2 hours after the start of the meal, less than 180 milligrams per deciliter. The recommended A1C goal for most adults is less than 7%. For blood fat levels, total cholesterol goal is less than 200. HDL for men greater than 40, for women greater than 50. LDL goal less than 100, and triglycerides less than 150. Blood pressure goals less than 140 over 80. Thought I'd add some pediatric target goals in here as well. Pediatric goals are less stringent. More stringent goals may be advised based on the child's age, maturity level, and their risk of hypoglycemia. Obviously, it would also depend on the amount of support they are getting for their diabetes as well. But toddlers and preschoolers, before meals, 100 to 180 is acceptable. At bedtime, you want them a little higher, like at 110, anywhere between 110 and 200, and an A1C goal of less than 8.5. School-age children, 6 to 12, 90 to 180 before meals, 100 to 180 at bedtime, less than 8 for an A1C goal. And then adolescents and young adults, look more like adults, 90 to 130 before meals, 90 to 150 bedtime, and then less than 7.5 A1C goal. And the reason the bedtime is in there is for prevention of nocturnal hypoglycemia. Let's talk about weight reduction. And what the ADA says is that weight reduction is recommended for all overweight or obese patients who have or are at risk for diabetes. Moderate weight loss is shown to have some benefits, and moderate weight loss is a 7 to 8.5% of current body weight. And what moderate weight loss can do is decrease insulin resistance, improve measures of glycemia and lipidemia, and reduce blood pressure. Moderate weight loss can also help in the prevention of diabetes in people who have been diagnosed with impaired fasting glucose or prediabetes. The body mass index you may already be familiar with, but it is a measures body weight in relationship to chronic disease risk. And there are some limitations to BMI. It doesn't take into account body weight, weight that is influenced by your muscle mass. However, it is a pretty good indication of risk for chronic disease, and so a normal BMI is 19 to 24. You are considered overweight with a BMI of 25 to 29. Obese would be a BMI of 30 to 39, and then extreme obesity, 40 to 54. Obviously, the higher the BMI, the greater the chronic disease risk, the greater the risk of developing diabetes. When it comes to weight reduction diets, there's no optimal macronutrient distribution. Weight loss is recommended really by reducing energy intake and maintaining a healthful eating pattern, which means eating healthier foods, reducing the amount of concentrated sweets and empty calories in the diet. For women to achieve weight loss, and women, it's unfair, I know, but it's usually about 1,200 to 1,500 calories a day for us to lose. And some women, especially elderly women, sometimes need less than that or require less than that to lose. Men can go with more calories and still lose weight, so 1,800 to 2,000 calories a day is usually what's needed for most men to lose. Weight loss goal is 1/2 to 2 pounds per week. I have patients tell me a lot that they lost 5 pounds in a week and they are proud of themselves, and you want to be there with them and help encourage them, but they need to understand that more than a 2-pound weight loss per week is not a healthy weight loss. They're not losing the right kind of weight in that situation. So how to lose weight? It's about lifestyle change. That's the primary approach. And the people who have success with weight loss are usually those that do obtain some form of counseling or go through classes such as Weight Watchers, some type of program. But the counseling should include nutrition therapy, physical activity, and behavior change counseling, and ongoing support is necessary for most people to be able to keep the weight off. It is recommended that an adult with a BMI of greater than 35 consider bariatric surgery, especially if they have diabetes or other core morbidities that are influencing their health. Okay, let's move on. Let's talk about the nutrition therapy recommendations just for diabetes. Macronutrients, there is no ideal percentage of calories from carbohydrate, protein, and fat that are recommended. The distribution of macronutrients is based on the individual. and should be assessed. Their eating patterns should be assessed, as well as their preferences and their metabolic goals, before developing a macronutrient plan for the patient. Carbohydrates are the key component to controlling blood sugar in people with diabetes. Collaborative goals should be developed with the individual to determine the amount of carbohydrate needed. The amount of carbohydrates and available insulin, either exogenously or endogenously, may be the most important factor influencing the glycemic response after eating. And should be considered when developing the eating plan. So, monitoring carbohydrate intake, whether by carbohydrate counting or experience based estimation, still remains a key strategy in achieving glycemic control. It's also recommended for good health that carbohydrate intake be from healthy foods, such as vegetables, fruits, whole grains, dairy products, etc., and that concentrated sweets and sugars be limited in the diet. Free fructose is a form of sugar, and free fructose is naturally occurring in foods such as fruit. That's the type of sugar in fruit is free fructose. And it may actually help to improve glucose control without raising triglyceride levels. It is recommended that you do not exceed greater than 12% of your energy needs from free fructose. So even though fruit is a healthy food, I always make it a point with my patients who have diabetes to help them understand that fructose can still or may still have a little bit of an effect on the blood sugar. Fruit has calories in it, and it doesn't mean that they can have as much as they may want. It is recommended that sugar-sweetened beverages be limited or avoided because they contain high fructose corn syrup and sucrose, both of which add calories without any nutritional benefit. And by limiting sugar-sweetened beverages, you reduce your risk for weight gain and for worsening of your metabolic risk profile. It is also recommended that if you do eat sucrose, that you would substitute it for other carbohydrate sources in the diet. And the reason is so that, and you want to minimize your intake of sucrose, and the reason is to avoid displacing nutrient-dense food choices. Also, it is recommended if you do eat sucrose that you cover with insulin or other glucose-lowering medications. You also want to eat it within the context of a healthy diet and avoid excess energy intake. There's a lot of things coming out about artificial sweeteners and sugar alcohols, but the American Diabetes Association stance on it is still that they are FDA approved and they may help reduce overall calorie and carbohydrate intake, but should be used in moderation. But they don't really give an example of what moderation is. Some examples of hypocaloric sweeteners you are probably familiar with. Saccharin is sweet and low, and that's the pink packet. Aspartame is equal, that's the blue packet. And then sucralose is Splenda, which is the yellow packet. And when I talk to patients about these, it helps if I just say the color of the packet because they don't always understand the names or know the names of the sweeteners they're using. Examples of sugar alcohol, Truvia is a sugar alcohol actually, and it's in a green packet, but other sugar alcohols, lactitol, mannitol, sorbitol, hydrogenated starch, isomalt, or some other examples. Sugar alcohols do have some unpleasant side effects. So some of the disadvantages of using these artificial sweeteners is that food products containing these may still have a significant amount of carbohydrate, calories, and fat. Many of my patients will tell me that they're eating sugar-free candy or sugar-free pies, and even though that does cut down on the carbohydrates some, patients don't realize that the crust in a pie has flour, and flour is a carbohydrate and affects their blood sugar control. So patients need to understand that sugar-free does not mean carbohydrate-free. There's often more saturated and or trans fat in these products as well. Oftentimes manufacturers will, when they take out the sugar to add flavor to an item, they'll add extra fat to make it more palatable. Sugar alcohols can have a laxative effect or other gastric symptoms, especially in people who aren't used to them. And so it's best if you start small and only eat small quantities of them to let your GI tract get used to it. And then sugar-free foods often cost more, and these days that's something people are having more and more of a problem with, is affording diabetes medication, supplies, and healthy foods. Dietary fiber is an important part of a person with diabetes, of their diet, and in everyone's diet. People with diabetes should consume at least the amount of fiber and whole grains that is recommended for the general public. The recommendation is 14 grams of fiber for every 1,000 calories eaten per day. So for women, that would be about 25 grams a day, and for men, that would be about 38 grams per day. A definition of whole grains would be foods that contain the entire grain seed, the bran, germ, and the endosperm. I think manufacturers mislead people when they buy things like bread. Just because the bread is brown does not mean it's got any added benefit. It needs to say on the label 100% whole grain or 100% whole wheat in order for you to gain the benefit of extra fiber from that bread product. Protein, again, there is no recommendation for the amount of this type of macronutrient in the diet. Basically, it should be individualized to meet the goals of the patient. It was once thought that people with kidney disease would benefit from a protein reduction, but that is also not recommended for people with kidney disease. Do not use protein to treat or prevent hypoglycemia, especially at bedtime. And that tends to be the recommendation you hear a lot, is have a protein and a starch at bedtime to prevent low blood sugar reactions. And the reason you don't want to do that is because protein doesn't increase plasma glucose, but it can increase serum insulin response and actually lead to more problems with hypoglycemia. Total fat, just as protein, the amount is individualized to meet the goals of the patient. The quality of fat is more important than the quantity. So the recommendations for saturated fat, cholesterol, and trans fat are the same as for the general public. Less than 10% of calories from saturated fatty acids per day is recommended, and then you want to replace saturated fats with more monounsaturated and polyunsaturated fatty acids. The recommendation for cholesterol is less than 300 milligrams per day, and then limit trans fat as much as possible, limit partially hydrogenated oils and solid fats. So, foods to limit or avoid. Animal fat is highly saturated and high in cholesterol. So many of your high fat meats and dairy products, such as fatty beef, lamb, pork, poultry with skin, lard, cream, butter, cheeses, and your whole milk, even 2% milk, has more saturated fat and cholesterol in it than we need. Many baked goods and fried foods are high in these bad kinds of fats as well. And then some plant foods do contain saturated fat, such as palm oil, palm kernel oil, and coconut oil. If a fat turns into a solid at room temperature, that's a good sign that it's high in saturated fat or cholesterol, or it's been modified with a lot of trans fat added to it to make it solid because it's naturally a liquid. Mono and polyunsaturated fatty acids can benefit glycemic control and also lower cardiovascular disease risk factors. Foods high in monounsaturated fats would be a lot of your vegetable oils, olive oil, canola, peanut, sunflower, and sesame oils are high in monounsaturated fat. Other sources, avocados, peanut butter, many nuts and seeds. Foods high in polyunsaturated fat would be soybean and corn oil, fatty fish such as salmon, mackerel, herring, and trout. And then also some nuts and seeds such as walnuts and sunflower seeds contain polyunsaturated fats as well. And what patients need to understand is even though these are good fats, fats are more concentrated in calories. There's 9 calories per gram of fat. And so even if they eat the good fats, they could gain weight and it could cause problems with their diabetes because of their weight gain. Omega-3 fatty acids would be your long chain omega-3 fatty acids such as EPA and DHA, and then your omega-3 linolenic acid, which is ALA. They do have beneficial effects on lipoproteins, help to prevent heart disease, and promote positive health outcomes. Foods high in omega-3 would be fatty fish, so salmon, mackerel, herring, lake trout, sardines, and albacore tuna. And it is recommended that you eat fish 2 times a week to get plenty of omega-3 fatty acids in your diet. Plant stanols and sterols. They can help to block the intestinal absorption of dietary and biliary cholesterol. They're typically found in enriched foods, and the recommendation is 1.6 to 3 grams per day because they can or they may modestly reduce total and LDL cholesterol level. Let's talk about micronutrients and herbal supplements. I think every day I have a patient tell me that they're taking cinnamon to help control their diabetes, or some weird supplement you hear about on TV that takes diabetes away. And the ADA stance on that is there's no supplement that has been that is shown in studies to really help the diabetes. So it's really not advisable to teach patients to take more vitamin E, C, or carotene. Plus, you can overdose on those particular vitamins. And then there's insufficient evidence to support the use of chromium, magnesium, vitamin D, cinnamon, or any other herbal supplement. We should teach patients to optimize food choices. They shouldn't need extra vitamin D. They shouldn't need more magnesium if they're eating healthy foods and trying to eat a well-balanced diet. Alcohol. You can't tell your patients not to drink alcohol. Most of them do, and it's something that does need to be addressed with the patient every time or when you are counseling them. And they need to know what moderation is. Moderation is different for everybody, or everybody has a different opinion of that. But moderation for women is 1 drink or less per day. Moderation for men is 2 drinks or less per day. And a serving of an alcoholic beverage is 1 12-ounce beer, 5 ounces of wine, 1.5 ounces of distilled spirits. I do recommend that they don't do mixed drinks. Now, I talked to them about there's a lot of sugar being added to margaritas, strawberry daiquiris, things like that. I recommend that if they're doing, like vodka, things like that, that they mix it with diet soda instead of regular, and that will help to cut down on the carbohydrate. Alcohol can cause an increased risk of hypoglycemia, and therefore we should teach our patients that they need to consume alcohol with food, and they don't have to count the carb in it and cover it with any insulin or anything. It's separate from that, and that's to prevent hypoglycemia. We need to teach a patient to abstain or advise them to abstain from alcohol if they have a history of alcohol abuse or dependence. Obviously, a pregnant woman would need to abstain. And if they have medical conditions such as cirrhosis, pancreatitis, neuropathy, hypertriglyceridemia, it is strongly advisable that they do not drink alcohol. And we need to make sure we're teaching our patients this. The recommendation for sodium is the same as for the general population. Less than 2,300 milligrams per day is recommended. Certain health conditions or older adults might need more of a restriction, like less than 1,500 milligrams a day. But considerations must be given to palatability of the food, because when you take sodium away, it does affect the palatability of the product, availability, additional cost, and difficulty finding these types of foods as well. When I talk to patients about reducing sodium, I really talk to them about 3 major things. Number 1, avoid processed meats like hot dogs, bologna, any packaged lunch meat needs to be avoided. If they eat lunch meat, they need to go to the deli counter and get it sliced. It will be lower in sodium. Second, avoid canned vegetables. Do fresh or frozen veggies. If they do have to eat canned vegetables, then they need to be low sodium. And number 3, soups. Avoid canned soups, packaged soups. It is better to make soups from scratch so that you can have control over the amount of sodium added to them. Obviously, you want to talk about the salt shaker, not adding any extra salt to food at the table. They need to taste their food before they would add any flavoring. Mrs. Dash is the go-to herbal product to replace sodium and add flavor. Lots of my patients don't like Mrs. Dash, or they don't like the typical or the first Mrs. Dash blend that was available in the yellow container. But now there are different herbal blends made by Mrs. Dash that are better, and people are having more success using those than they used to, I'm finding. Okay, let's talk about healthful eating patterns. So what can we teach our patients, or what kind of eating pattern would be best for them? And there's no one diabetic or weight loss eating pattern that is better than another. Really, it depends on the patient and what they feel comfortable doing, what they feel like they can afford, and what fits into their lifestyle. The amount of carbohydrate intake from any of the eating patterns I'm going to go through will affect blood glucose levels. You do not want to restrict carbohydrate to less than 130 grams per day, however, because the body does need a certain amount of carbohydrate to function. Unfortunately, carbohydrate gets a bad rap, but it is a necessary, vital nutrient to our body and to our metabolism, and we need it. We just don't need too much of it. And that's what I tell my patients every day. So types of eating patterns. There's the Mediterranean, the DASH diet, which has been around forever, vegan and vegetarian diets, low fat and low carbohydrate diets. So let's talk about Mediterranean first. A Mediterranean style diet is mainly plant food based. It includes a lot of fruits, vegetables, whole grain breads, and cereals, beans, nuts, and seeds are big in this type of eating pattern as well. Minimally processed. The foods need to be fresh. Locally grown foods are incorporated in this type of eating pattern. Very low amounts of concentrated sugars or honey. Olive oil is the main source of fat in this type of eating pattern. Dairy products are okay in low to moderate amounts, and they need to be low-fat dairy products. Fewer than 4 eggs per week. Red wine should be eaten in low frequency and amounts. Wine it is okay to drink in low to moderate amounts. More protein is gotten from fish in this diet than usually from any other source. It's often known as the fish diet sometimes, I think. The DASH eating pattern is similar to the Mediterranean eating pattern, except it places more of an emphasis on losing body weight and reducing sodium intake. But still, it recommends increasing the intake of fruits and vegetables up to 8 to 10 servings a day, low-fat dairy products, more poultry, fish, and nuts, less saturated fat, especially from red meat, less sugar-sweetened beverages and concentrated sweets, and then avoid excess alcohol intake as well. Vegan and vegetarian eating patterns. Vegan diets are diets devoid of all flesh foods and animal-derived products, whereas vegetarian diets are devoid of all flesh foods but include eggs and dairy products. They both can reduce the risk of chronic disease because they lower intake of saturated fat and cholesterol. And people who use these types of eating patterns have much higher intakes of fruits, vegetables, whole grains, nuts, phytochemicals, healthy foods. It forces you into eating healthy foods, or you're not going to get the nutrition that you need when you're avoiding meat. And what I tell patients who are interested in this type of eating pattern is I think it's very important they sit down with a dietitian to help them develop a meal plan before they would start something like this, because it is difficult to find to get the protein that's needed from plant sources. You have to have a variety of different types of plant sources to get the protein that's needed. The low-fat eating pattern, again, focuses on eating more vegetables, fruits, starches, leaner proteins, and low-fat dairy products. Low fat tends to be the go-to for weight loss, and that makes sense because fat is more concentrated in calories than other nutrients. And so by decreasing your fat, you are able to get rid of some extra calories in your diet and lose weight. And then low carbohydrate eating patterns. They're okay to use as well, but they focus on eating foods higher in protein, fats, and then vegetables that are lower in carbohydrate. Carbohydrate allowed in these types of eating patterns varies by the plan. And then sugar-containing foods and grain products are generally avoided, and that's a good thing. People who follow this type of eating plan do need to see their doctor regularly, as it can influence or affect their some of their lipid values. And so it's just important that monitoring by a physician is obtained regularly when following this eating pattern. A simple meal planning approach may be better in certain situations or for some individuals. For instance, some of your elderly, I know I work in a hospital and a lot of my patients are elderly. It wouldn't be appropriate for them to start something as complex as a Mediterranean or a DASH diet sometimes. So, you may want to focus in that type of situation. You may want to just focus on healthy food choices. Listen to what they usually eat and then help them decide where changes need to be made or what foods can be swapped for something different to decrease the sodium in their diet or the fat in their diet or whatever is needed. And then portion control is something that could just be the only focus you have with your patients. Many of my diabetic patients are eating healthy foods, but they're eating them in the wrong portions. And so it is important that portion control is discussed every time you discuss meal planning, but may be a little more simple of a concept than other things would be. And also, a lot of our patients have health and numeracy literacy concerns. And I know right now in the literature, health literacy is a big topic, and it is a problem. And I know that many of my patients would have trouble carbohydrate counting or following a complex type of regimen, and it's better to do simple things like focusing on one particular food group to help meet their needs. So just an overview of some of the priority topics that you would want to focus on when counseling a patient who has diabetes. Number one, healthful food choices. Carbohydrate is okay, but it needs to come from whole grains and fruits and vegetables. Portion control. It's important for all of us to use good portion control, and especially for someone who is wanting to lose weight or maintain their weight. Reduce your total caloric intake when needed. If you're trying to lose weight, don't worry so much about your proportion of carbohydrate or fat or protein. Worry more about your total calories, and change your high calorie foods or your beverage intake to help meet your calorie needs for weight loss. Avoid processed foods with added sodium, fat, and sugar. Avoid sugar-sweetened beverages. Substitute foods higher in saturated and trans fat for foods higher in monounsaturated and polyunsaturated fats. Select leaner protein sources and meat alternatives. More white meat, less red meat. Vitamin and mineral supplements, herbal products, and cinnamon are not recommended. You want to make sure you address that with your patients. And then limit sodium intake to less than 2,300 milligrams per day. Know your carbohydrate containing foods. At least know the food groups so you know what foods are affecting blood sugar. Choose good carbohydrates that are high in fiber and nutrient dense and distribute them evenly. You want to balance your intake of carbohydrate with medications and activity. So you want to make sure you eat carbohydrates at regular times and keep 4 to 6 hours between meals. Try not to skip meals. Eat about the same amount of carbohydrate at each meal. These are important concepts. Monitor the kind and amount of carbohydrates, either by carb counting, exchanges, or experience-based estimation, and then use alcohol in moderation and consume it with food for prevention of hypoglycemia. And remember that each nutrition plan should be and is individualized. Everybody's different. Let's talk about coordinating food with type of diabetes medication. Insulin secretagogues are medications that help the pancreas produce insulin. When I was in school, I remember them as many of your G meds, your medicines for diabetes that started with a G: glipizide, glyburide, glucotrol. Those are insulin secretagogues. And what matters with these is that you need to make sure that you do eat moderate amounts of carbohydrate at each meal and snack to reduce the risk of low blood sugars. And it's important not to skip meals on these medications. These medications should be taken with food. So if you have a patient who's on glipizide twice a day, it needs to be taken with breakfast and with supper. And then always carry a source of carbohydrate during physical activity, because this type of medication is more likely to cause low blood sugars when you're more physically active. Biguanide, that is metformin, been around a long time. It's a good drug. It can have some GI side effects. It can cause diarrhea and stomach upset when people first start that medication. It's better if it's started in a smaller dose and taken with food or 15 minutes after a meal. And I always teach my patients who are new to metformin that if their side effects do not resolve in a few weeks, or if they become severe, that they need to let their healthcare provider know. That's a very important teaching point for that particular medication. This metformin is less likely to cause hypoglycemia, but it can in some patients. And so I still teach, how to treat hypoglycemic events in people who are just taking this medication, and also teach them to make sure they're eating 3 meals a day and not skipping meals. Alpha glucosidase inhibitors can also have some GI side effects. It's recommended this drug be gradually titrated to minimize those. And it's important to remember to take these at the start of the meal because that's when they have their maximal effect. And if taken along with an insulin secretagogue or insulin, this medication may cause low blood sugars. If a low blood sugar occurs, it's important to remember to eat something containing monosaccharides, such as glucose tablets or glucose gel, because this group of medications can prevent the digestion of polysaccharides, which is table sugar. Sucrose is a polysaccharide. So when teaching patients who are on this, and an example of this medication is Precose, when teaching a patient on Precose, I always make sure to tell them to keep glucose tablets for treatment of low sugar, or gel, because it's a monosaccharide and will work quicker. Incretin mimetics, your GLP-1, it's also important to remember that this medication should be gradually titrated to minimize GI side effects. The injection should be pre-meal, and if side effects don't resolve in a few weeks, again, you want to teach to follow up with a healthcare provider. If they take this medication with an insulin secretagogue or insulin, they may experience hypoglycemia. The recommendation is the dose of insulin or insulin secretagogue should be decreased when starting a GLP-1 medication. And then there is, or has just recently been approved, a once weekly GLP-1 that it can be taken anytime during the day. With that one, it doesn't matter if it's taken before the meal or not. And again, it's just a once weekly. And a lot of people, it's called Bydureon. A lot of people are having success with that and less GI upset with it than with the Byetta, which is a daily injection of GLP-1. Insulin therapy, you have to be more concerned about carbohydrate intake, timing of meals in your patients who are receiving insulin therapy. And it's important for patients using insulin to learn how to quantify their carbohydrate or carbohydrate count. If patients are on meal dose or multiple daily insulin injections or an insulin pump, they should take their rapid acting meal dose insulin within 15 minutes of eating. I have had patients end up hospitalized because they took their rapid acting insulin at home, but it was an hour before they received their food at the restaurant and ended up having a low blood sugar and being hospitalized because of that. And so I always make it a point with my patients to make sure they understand they need to take their rapid acting insulin with them to the restaurant and inject when their food is in front of them. Meals can be consumed at different times on a meal dose insulin regimen. If physical activity is performed, it needs to be performed within 1 to 2 hours of meal dose insulin injections, and a dose adjustment may be needed to reduce your risk of hypoglycemia. Insulin to carb ratios are often used as a form of meal dose insulin, where a patient would get 1 unit of rapid acting insulin for every so many grams of carbohydrate they consume. And we'll discuss more about that when I talk about carb counting. And then for people on fixed daily rapid acting insulin doses, what matters is that they get a consistent carbohydrate amount with each meal, and that it's consistent with respect to time as well. For instance, if you have a patient who is supposed to take 10 units of Humalog with every meal, that 10 units of Humalog more than likely is based on a certain amount of carbohydrate being eaten at that meal. And if they eat less than a certain amount of carbohydrate but take their full 10 unit dose, that's going to cause hypoglycemia. And we want to try to avoid that. Or vice versa. If they take their 10 unit dose and go over the amount of carbohydrate that dose was intended for, they will have hyperglycemia. So it's important these patients test their blood sugars just to see how their blood sugars are reacting in response to the food that they're eating, and that they understand carbohydrate counting so that they get the most benefit out of their meal dose insulin. A pre-mixed insulin plan, this would be like somebody on Humalog 75-25, Novolin 70-30. Those are examples of pre-mixed insulins. It's important to remember to take this insulin at consistent times every day. It's also important to eat meals at similar times every day because these mixed insulins have 2 peaks in them. And if you don't eat when the insulin is peaking, it increases your chances of hypoglycemia. It's also important that patients on this type of insulin do not skip meals, and that when they are exercising, they carry a source of quick-acting carbohydrate, and probably will need a snack prior to exercise for prevention of hypoglycemia. These insulins do not allow for as much flexibility as a basal bolus insulin plan would. And then a fixed insulin plan, such as 1 shot of Lantus every day, what's recommended is that the patient eat similar amounts of carbohydrates each day to match the set doses of insulin that they're taking. And that, I think I said Lantus earlier, that would be for meal dose insulin. So that concludes this part or this section of Module 3. Um, if you will exit out of this and get into the carbohydrate counting presentation, we'll learn how to carbohydrate count